Good morning, friends. I am Dr. Captain D.K. Ramawat, consultant non-invasive cardiologist working at Ramawat Heart and General Medicine Hospital, Badmer, Rajasthan. And today we are taking one international chapter and very interesting chapter, the challenges in management of groin complications, routine and wide bore access. It is not the only pricking the femoral artery, but its complications. Groin complications have always been challenging. It is a serious matter. Let us discuss the matter. So let us start. Challenges in management of groin complications, routine and wide bore access. Challenges in management of groin complications, routine and wide bore access. First we take the introduction. In introduction, groin complications have always been challenging and it is of serious matter even with the routine access based procedure. But those associated with large bore are even more frightening and challenging and ultimately adversely affect the outcomes of the actual intervention. Large bore access procedure is one where the access vessel hemostasis cannot be achieved only by groin complications and will need a vascular closure device VCD or surgical closure to achieve complete hemostasis. There is no standardized definition. There is no standardized definition for large bore access, but conventionally more than 8 French sheath based procedure falls in this category, and if it is less than 8 French sheath, it is considered as routine access. Managing groin complications of femoral access route had been challenging and frightening many times. This led to a shift from the groin access to radial route, but now for more than a decade a sudden rise of structural interventions and mechanical circulatory support system has left no chance for us but go back to the groin and master the skills of femoral access and learn to face more serious complications. The complications not only adversely affect the outcomes of an interventional procedure but also lead to loss of life or limb and possibly raise the debate of medico-legal implications as well. Now, in second slide, I am going to take different large bore devices and their sheath sizes and major complications. So here there are 6 procedures you can see on the board. The first is percutaneous wall therapy, that is TAVI. Everybody knows the TAVI. Here French sheath is of 14 to 18 and complications will be, major complications will be 6 to 8%. Second, endovascular interventions, TEVAR and PEVAR. TEVAR means thoracic endovascular aortic aneurysm repair and PEVAR means percutaneous endovascular abdominal aorta aneurysm repair. Here the size of sheath will be 18 to 26 and major complications will be 14 to 20%. And third is left atrial appendages occlusion. Left atrial appendage occlusion, also known as left atrial appendage closure, is a procedure that reduces the risk of stroke in people with atrial fibrillation. During the procedure, a cardiologist inserts a device into the heart to close off the left atrial appendages, preventing blood clots from entering the bloodstream. And here sheath is 8 to 14 French, and major complications are 5 to 6%. Then the number 4th, mechanical circulatory support system. For example, extracorporeal membrane oxygenator, ESMO. Second, impella. And third is tandem heart. Now, here the sheath is 14 to 22 French, and major complications in impella is 6 to 14%. In tandem heart, it is 50 to 60%, and in ESMO, 30 to 50%. It is and now the 5th complication, 5th process are complex high risk patient, CHIP PCI. What is CHIP PCI? CHIP PCI stands for complex high risk PCI, indicated for percutaneous coronary intervention. Is a catheterized badge procedure used to treat patients with coronary heart diseases who are considered high risk. Patients with factors that increase the risk of procedure, such as advanced age, history of disease, or challenging plaque types, are considered in CHIP PCI. Here, the sheath is 8 to 22 French, and major complications are 5 to 15%. Then lastly, radial crossover PCI. What is radial crossover PCI? A radial crossover during a percutaneous coronary intervention is when the procedure switches from the radial artery to the femoral artery. This can happen during the diagnostic angiogram or the PCI procedure. Here, major complication can be 5%. Let us go for next. Here you can say complication from vascular anatomy of the groin. Here nothing to tell about it for you people, because everybody knows it. But you must see in 3rd figure, there the complications which are what? Perforation. You can see perforation, and AV fistula, and pseudoaneurysm. These are 3 main can happen during your perforation. Let us go forward. So, now we will see the selection of puncture site. You can see here the picture. This is regional anatomy relevant to percutaneous femoral arterial and venous catheterization. So, selection of puncture site. The adjacent femoral artery and vein in above figure are the most commonly used vessels for percutaneous diagnostic cardiac catheterization. Vessel puncture should be achieved between 1 and 3 cm below the inguinal ligament, which can be easily palpable as it courses from the anterior superior iliac spine to the pubic tubercle. While some operators rely on the location of inguinal skin crease rather than the inguinal ligament for the selection of puncture site, but the iliac spine and ligament continue to be the reliable anatomic landmarks. The femoral artery typically lies at the midpoint of the inguinal ligament and can be palpated over as several centimeter span distal to the ligament, and can be palpated over 2 to 8 cm in length. A diameter varies from 6 to 10 millimeter. It is 2 to 3 cm below the inguinal ligament and is the safest zone for puncture. It lies over the medial part of the femoral bone head. This vessel is identified as the point of maximum femoral impulse in the groin. The femoral vein lies approximately 1 finger breadth medial to the artery along a parallel course. Most difficulties in entering the femoral artery and vein and most vascular complications arise as a result of inadequate identification of these landmarks prior to attempted vessel puncture. Puncture of artery at or above the ligament make catheter advancement difficult and may predispose to inadequate compression, hematoma formation, retroperitoneal bleeding following catheter removal. Puncture of artery more than 3 cm below the inguinal ligament increase the chances that the femoral artery will have divided into its profunda and superficial femoral artery branches. Puncture in the crotch in this fork between these two branches fails to enter the arterial lumen, and puncture of either one of branch increase the risk of thrombotic occlusion due to smaller vessel caliber. Because the superficial femoral artery frequently overlies the femoral vein, low venous puncture may pass inadvertently through the superficial femoral artery, leading to excessive bleeding and possible arterial venous fistula formation. Now we have come to the complication of vascular access in the groin. This includes minor and major. So minor complications are simple ecchymosis and painful hematomas. And major life-threatening complications are: number 1, retroperitoneal hemorrhage; second, avulsion and rupture of vessel; third, hemodynamic collapse; fourth, amputation of lower limb; fifth, mortality. These major complications causing huge challenges of management to the physician. Here at box number 1 you can see groin complications with small and large bone access. First is pseudoaneurysm, second, arteriovenous fistula, third, retroperitoneal hemorrhage, fourth, large non-communicating hematoma. If it is more than 5 to 10 cm present, causes significant drop in hematocrit and needs surgical evacuation. And fifth is thrombosis, sixth, dissection, seventh, perforation and avulsion of the vessels. Eighth is vascular closure device related complications. Ninth, distal limb ischemia and amputation of lower limb. And 10th is major bleeding that is uncontrollable, causing hemodynamic collapse. And the second box you can see here, patients' factors increasing the chance of groin complications. Number 1 is the woman, second, old age, third, obesity and frail thin-filled person, fourth, small vessel wall, and fifth, blood disorders and patient on anticoagulants, sixth, peripheral vascular diseases, seventh, CKD and diabetes. Here, peripheral vascular diseases, the main forms of PVD may include blood clots, deep vein thrombosis, swelling, inflammation, or narrowing and blockage of the blood vessels. In third box, here you will see processual factor increasing groin complications. High or low puncture site. High means external iliac artery. Low means superficial femoral artery and popliteal femoral artery. Now second, multiple attempts to make venous or arterial access. Third, large sheath size. Fourth, previous procedures done. Fifth, use of ephesiomab, post thrombolysis or high heparinization. Ephesiomab, you know, is a prescription medicine that reduces the risk of heart attack in patients undergoing percutaneous coronary intervention. Ephesiomab is used in combination with aspirin and heparin, which are other medications that prevent blood clotting. Then sixth is quick reversal of heparin in large bore access. And seventh is posterior wall puncture, posterior vessel wall puncture. It is to reduce this complication, needle guides have been used, though current methods have limited accessibility and generalizability. The aim is how a self-made needle block constructed with materials present in central line kit can reduce the increased incidence of posterior vessel wall puncture. And here then the seventh is femoral artery and venous puncture through and through. And ninth is large bore access more than small bore access. And 10th is the last one, vascular closure devices related complications. What are those? We have to discuss here. Vascular closure devices complications, they include first bleeding, the most common complication occurring in about 70% of the patients. Second, infection, the second most common complication occurring in about 39% of the cases. Third, the ischemia occurs in about 28% cases. These are the vascular closure devices complications we are discussing. Listen it carefully. Then fourth, pseudoaneurysm present in about 20% of cases. Then hematomas, a complication of VCD use. And then sixth, arteriovenous fistulas, a complication of VCD fuse. Then lastly, seventh point, retroperitoneal bleeding, a complication of VCD failure. Other complications include dissection of the artery, thrombosis, failure of device, and distal embolization. Now we have come to challenges. Challenges of the management of groin complications. The first is in the small bore access procedure. Serious complications happen mostly when the operator lapses on small points. For example, site of puncture, pushing the guide wire and sheath inadvertently against resistance. Second, improper groin compression. Third, forgetting to flush sidearms and ports of the sheaths. Fourth, missing on monitoring for a delayed bleeding. Fifth, inadequate supervision of groin by the nursing staff or trainees and fellows. Sixth is poor preparedness to handle a complication. For example, blood grouping, cross-matching not performed, the safety kit for bailout from complication not kept, and non-availability of hardware such as coils and covered stands not kept. The major challenges have here constitute what? Number one, not sticking to basis of the access. Second, proper groin complication not done, then following complication may occur. For example, retroperitoneal hemorrhage, pseudoaneurysm formation, arteriovenous fistula, groin hematoma, femoral artery dissection, and femoral artery occlusion. All these complications influence procedural outcomes adversely by increasing the morbidity, length of hospital stay, requirement of blood transfusions, need for surgical and interventional repair, and total cost of primary procedure. Then another point, acute kidney injury and infection or other serious complications as a consequence to the use of more contrast and instrumentation during bailout procedure. Then acuity trial says what? It says has showed a sevenfold increase in mortality, with major bleeding complications. And what is a partner trial? Partner trial data shows that mortality doubled with increase in major vascular complications. The benefits of mechanical circulatory support system for a high risk PCI gets undermined from such serious vascular complications. Now pre-planning with imaging studies is a good practice for large bore access. For example, computed tomography angiogram CTA is the gold standard. I repeat again, computed tomography angiogram CTA is the gold standard, and intravascular ultrasound is the second, and angiogram is the least information giving modality for imaging. CTA gives the details such as size of the artery, tortuosity, circumferential extent of calcium in the vessel, hostile vasculature, or a very compliant good size of the vessel. If the conventional femoral artery has peripheral vascular disease, then alternate access should be considered. If the femoral external iliac artery system is less than 5 to 5.5 millimeter, alternate access should be done through axillary, carotid, subclavian, transcaval and direct apical approaches should be considered. IV lithotripsy modification of a calcified femoral iliac artery has been made suitable and accommodation to do the transfemoral access successfully. Minimum 5 millimeter vessel is required for a 14 French sheath. Now large bore access complications are what? Number 1, a massive uncontrollable exsanguinating blood from perforated or avulsed artery. Second, tear of iliac artery, most dangerous, and challenges lies how quickly the bleeding is stopped and volume is replaced. C, surgical backup will be required as a last resort if it is not controlled by interventionist armamentarium and not available by covered stent interventional technique. So, occluding balloons proximal to the site of avulsion or tear, or how typically surgically repair or stenting is done, is most vital, or else the patient will exsanguinate and die. Stent of right size generally 6 to 10 millimeter caliber iliac is used. It is vital to supplement volume of fluid and blood for blood loss. Then the hypertension will occur here. So for hypertension from bleed of avulsed artery is never managed by inotropes, which can just cause worsening vasoconstriction and worsen metabolic acidosis. Blood and crystalloid in sufficient amount should be transfused and acidosis will get corrected gradually as the volume are replaced and hypertension is corrected. Dry field technique. Second, at the time of vascular closure step, can be achieved by occluding with an inflated balloon proximal to puncture point and is good method of safety against the chance of major blood loss from the large bore access site. The dry field technique. It is a vascular access control procedure that involves using a balloon to occlude the external iliac artery and then removing the balloon and finalizing closure. The technique is used when there is high risk of bleeding. Thrombotic occlusion of large vessel causing acute limb ischemia. Here what we will do, should be quickly detected and needful thrombectomy done in the time before lactate accumulate up in the blood. Before lactate accumulate up in the blood and causing hypertension from lactic acidosis and causing cell death of muscles of limb from ischemia, and the lactate level further develop irreversible shock state leading to kidney shutdown. Now drop in ACT. Drop in ACT is a major common cause of such major thrombosis happening during the procedure or toward the end of it when large sheaths are in situ, especially when protemin reversible is done in haste at the time of access closure. Remember, ACT is maintained at 250 to 300 seconds throughout the procedure. Non-attention to contralateral sheath, if done, for example, unflushed can have thrombotic occlusion and detected late when critical limb ischemia sets in. A large bore access is defined. Where it is defined large bore access? Large bore access is defined successful when only if the access is done safely and the intervention ends with effective hemostasis after removal of large seeds and devices or delivery system. Then only we can say that a large bore access is successful. Otherwise, no. Here, protection of acute distal limb ischemia. It is very important. Learning the asthma circuit and maintaining distal flow in the large bore cannulated limb is mandatory, or else limb will be jeopardy, means there will be danger of loss of the limb. Inserting the steps of impella sheath should be well acquainted by the cardiologist or physicians. Serial lactate measurements are the marker of limb perfusion. Thromboembolism and plaque embolization downstream causing tibioperoneal occlusion should be ruled out by angiogram after sheath removal. Serial lactate measurement are a series of blood lactate levels determinations that can be used to predict the development of multiple organ failure and death in patients with septic shock. Here the picture is when large bore access sheath is kept for several hours or days, distal limb perfusion maintained by antegrade puncture and special circuits of bypass from some other limbs created. You can see. Now we are coming to VCD, vascular closure devices. Advantage and challenges of vascular closure devices. It helps achieving good vascular closure in large bore access and helps quick ambulation, but at the same time associated with complications such as infection, embolization, device failure, leading to ischemia or excess site bleeding, or rarely non-retrievability of the device requiring surgical explant. Large bore access closure is a procedure that uses vascular closure devices to close a small hole in an artery after an angiographic procedure. VCDs are an alternative to manual compression. I again repeat, VCDs are an alternative to manual compression. Manual compression can take a long time and requires patient to lie flat for several hours. VCD inserted at lower limb in superficial femoral artery with smaller caliber, which can cause excessive narrowing and pathological stenosis at the time of suture. A rare complication of suturing the pigtail catheter used to make bull's eye can happen if the catheter is not pulled out after access and before putting the suture bite of pre-closing. Here you can see vascular closure device. Now, in the last but not the least, I have come to the conclusion. Here I will show you the fourth box, which contains 10 commandments of avoiding and managing groin complications in large bore access. First is pre-planning by imaging studies is essential for large bore access. Second, micropuncture technique under ultrasound or fluoro guidance is excellent way of a successful and safe puncture. Third point, puncture always should be below inferior epigastric artery and above the bifurcation of common femoral artery. Careful upgradation of sheath done over stiff wire, especially in hostile anatomy. Fifth, adequate heparinization till removal of sheath. Sixth, preparedness, safety kit and blood products and surgical backup availability should be ensured before starting the procedure. Seventh, familiarity with the use of vascular closure device should be done. Then enough resting hours given to patient after access vessel closure. And eighth, enough I have told. Ninth, alertness, monitoring, detecting, staying cool, and taking rightly is key to manage the complications. Lastly, number 10th, maintaining distal limb perfusion and watchful care of contralateral femoral access route should be never forgotten. Now, in the era of large bore access needing procedures, more serious and life-threatening groin complications can be faced than those with routine access. Practicing and sharpening the skills of femoral access in the present radial age is essential for interventionists. Complications in groin can happen even if the best practices are adhered, but the preparedness to handle and bail out is what will make you different from the others. Time lost is a life lost. Time lost is a life lost. It's just unacceptable. Lastly, the challenge of burden on physician would be facing the medico-legal implications and hence detailed documentation of vascular access processes, monitoring and actions taken in the event of complication must become a routine practice. I again repeat, lastly, the challenge of burden on physician would be facing the medico-legal implication and hence detailed documentation of vascular access processes, monitoring and action taken in the event of complication must become a routine practice. Auditing complications of groin access help improve the institutional outcome of interventional procedure. Thank you.